Namaskar and good evening, everyone. I welcome you all for today's webinar on Oncology Update 2024. With immense pleasure, I would like to invite Dr. Ishu Gupta, who is consultant medical oncologist at Unique Hospital, New Delhi, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Hi, good evening, everybody. Thank you for joining with us today. Today, it is my pleasure to invite you all to the Oncology Update 2024, where we have our esteemed uh, experts who would be discussing on the recent updates in hematology as well as oncology. So, without keeping everybody awaiting, I would like to invite Dr. Isha Kaul for the first panel discussion, on which is about the ask the stamp experts, that is the role of asciminib and the mechanism of it in CML. And over to you, ma'am. I would like you to invite your panelists, please. Thank you.
Hi, good evening, everyone. Can you allow me to share, please? Okay, got it. Are my slides visible?
Yes, ma'am. Just make
Okay.
it full screen, ma'am.
Yes. So let me just
Yeah.
go back. Sorry. Let's get this going. So for I think the first part of this session is hematology, and then you guys go on to do some oncology later on. The panel that we are talking about today is on the role of asciminib, which has become available now in India. And so how we use it, how we position it, how we think about it. And for the purpose of this discussion, we have two wonderful panelists. It's my pleasure to invite Dr. Nivedita Dhingra. Dr. Nivedita is a principal consultant in hematology, oncology, bone marrow transplant at Max Parparganj. Welcome, Dr. Nivedita.
Thank you, Dr. Isha.
And we also have with us Dr. Anshul Gupta, who is who is a consultant medical oncology at Max Vaishali and Max Noida. Uh, Hi again,
Ma'am,
Dr.
good evening.
Anshul.
Yeah. Good evening, ma'am.
All right, so these are just the standard disclaimer slides. So we have a slide set, but since this is, I think just to keep it a little bit interactive, I might veer off the script a little bit here and there. So, you know, that the core patient population that we are discussing about today is patients in CML who are second line or more therapy wise. So we know that TKIs have been a game changer and they have been around now for over 2 decades, and we've all used them, and we can see how drastically it has transformed the situation for patients and providers like us in CML. But as time goes by, we become more greedy, and obviously we want the patients to do even better. And this relatively small percentage of patients who are not doing so well on TKIs or having intolerances, so or having quality of life issues. So even though TKIs have been very, very successful, I think we can all acknowledge that once there is a proportion of patients who struggle, and so hence uh, the desire to try and do more for these patients. And that is where the second and third generation TKIs have also come along with their varying toxicities and administration schedules. But the interesting thing about asciminib is that it is not a TKI. So I think the one thing which was, refreshing when this molecule came around was the fact that we had a completely different mechanism of action, it being a stamp inhibitor, which is very different in terms of where it binds on the abyl kinase domain. And so the traditional issues that are, the IRMA, the imatinib resistance mutations, it bypasses all of that by virtue of its mechanism of action. So this was something that happened, after a long time in CML, that we had a non-TKI modality of treatment. So now that this molecule was studied and evaluated, where do we position this in our lines of treatment? I think this is just the data that we'll talk about. I'll go to the questions. Dr. Nivedita, if I can bring you in here, what is your approach to first line treatment? Or let me just like take it further and say that if you have given something, any TKI, whatever, as first line, and the patient is not doing well, what is your threshold for changing to second line therapy? How do you decide, make that decision just in your clinical experience?
So when we start a patient on TKI, we generally tend to monitor the BCR-ABL levels at 3 monthly intervals. And if the patient is not meeting milestones, the desired milestones at 3 months or 6 months, by 6 months, if the BCR-ABL is not less than 10%, then I would definitely plan to change the TKI. So if I'm starting with imatinib, I'll probably go on to a second generation TKI, which is more commonly dasatinib because of its ease of administration and once daily dosing.
Like going to dasatinib as the second line.
Yeah,
So,
in
Dr.
most
Anshul,
cases.
most cases. Dr. Anshul, how do you sequence TKIs? I think the slide set that I have is not the panel discussion one, it is the descriptive one.
That's
Can
a
I
manual.
ask?
Uh,
Yeah, but I think they can just, it's the same content. I think it is just that it is a different slide set. Maybe somebody can project the one with the panel discussion from the organization side, but we'll just continue and discuss while that is happening. Dr. Anshul, your thoughts on how you sequence treatments in CML? What is your first line that you usually go to?
Okay, so ma'am, on my first line, I'm still a bit of old school. I still start with the imatinib for most of my patients. Okay.
Okay,
And subsequently, as Dr. Nivedita said, I follow them with the BCR-ABL. Of course, initial being we see first hematological response, and hardly anybody now does a chromosomal response, or so we then follow with BCR-ABL. And if the milestones are not being met, then I would rather switch to a second generation TKI swiftly after doing IRMA studies, and after ruling out any additional clonal abnormalities.
okay. So, how often do you switch for intolerances? So, is a more common reason to switch not meeting milestones, or is the more common thing intolerance?
So intolerances mostly, ma'am, in the second generation TKIs. Imatinib is reasonably well tolerated. Occasional patient requires dosing to 300 mg. But yes, when it comes to second generation TKIs, whether we use them upfront or in the second line or on progression or something, so we do have a tolerance. Dasatinib, pleural effusions, and cytopenia sometimes are related to the treatment. They are not manageable, so that becomes a challenge.
Right. Dr. Nivedita, your thoughts on, do you think in your experience, not even think, just in your experience, is intolerance a more common reason for switching, or is it more uh, not meeting milestones, like lack
So
of adequate response?
I completely agree with Dr. Anshul on this that intolerance is the more common reason for switching. And often, there is dose reduction, sometimes there is therapy interruption. And all of these, I think it sets up a vicious cycle where you can get emergence of resistance also. You can have mutations that result from intolerance. I think the two are somewhere linked as well. But
Yeah.
intolerance is more common reason than resistance in actual clinical practice.
So I think you bring out a very important point that a lot of times patients who are having cytopenias are also the patients who are not meeting milestones. Um, but the data which clearly shows is that once patients start developing, they go beyond second generation, the outcomes, start dropping. We now anticipate near normal life expectancy for patients with CML, but the slides which I'm just going to show you, in a moment, and the studies, they confirm that once you have second line, more than second line, even with second line, long term uh, survival is in the tune of 70 to 75%. But once you go beyond that, then it really drops. I'm hoping I have the right slide set now.
I think there is only one slide set. They've just put some questions.
Yeah, I think that is the same slide set. I don't know. I'm just
Pretty
trying
much.
to pretty much the same thing. All right. Just give me a second to share again. Okay. Is this the one? Can you see my slide sets? This one?
Yes, yes, yes. Your slides are
Okay, this is the
visible.
one with the red questions now. Okay. So I think, yeah, so this is, we agree, and I think this is not even a question. We can all agree that once we go beyond second line of treatment, the overall survival starts dropping by 10%. Dr. Niveta, you said already that your first go-to is dasatinib. But in just picking, what are the patient characteristics or the disease characteristics that you take into consideration when choosing second line or more than second line treatment for the patient who's not doing well with the first TKI?
So my first line is not always dasatinib. So a lot of
Okay,
factors go into choosing the first line TKI for a particular patient. For older patients, still I would prefer to use imatinib only,
okay,
because I don't think there's any difference in overall survival, and imatinib being the oldest, most well-studied, most well-tolerated. For certain young patients who have a high SOCAN score, recently I have started incorporating dasatinib in first line. But
okay.
what I've noticed over time is that yes, definitely the side effects with dasatinib are much more than imatinib. Uh, Recently, I had a patient on dasatinib who had CMV colitis. So
Mm-hmm.
pleural effusions are the norm. And generally, once the patient starts losing response to a second line TKI, if it's a young patient, definitely the discussion on transplant also comes into being. You do start thinking of it as a curative treatment. For an older patient, if with the dose reduction, before switching a TKI, I think one thing that needs to be considered is that dose reduction can be done. And that there is data to suggest that even that can maintain a good response. And there is some real world data to even suggest that ideally we want our BCR able to be less than 1%. But even if it is less than 10% and they're able to maintain that with a reasonably good quality of life, I would not be very hasty in changing the TKI. Rapid and indiscriminate changing of TKIs and cycling of TKIs is something that should not be done. So, for a young patient, if there is a failure to a second generation TKI, definitely thinking of transplant it comes on the table. For older patients, dose reductions is what I would go for first before switching, because each TKI there are overlapping toxicities and unique toxicities with each TKI.
Yeah, I think you bring out a very important point, of the rapid cycling of TKIs. We see this a lot. I think because just the fact that when imatinib was the only drug available and the other second generation were expensive, people were not getting a lot of intolerances. I mean, we did not designate patients as having intolerance. Patients did not say, but now that we know other options are available, very quickly sometimes we might say, or the patient might say, oh, I'm having cough with this, or I'm having a little GI something. So the fact that more than several lines of therapy are available, because intolerance is something which is very subjective sometimes, that you label
Absolutely.
something as being there are clear markers for response, but intolerance can be very subjective on part of both the patient and the doctor. The other question, I think, and on the point, I think just I'm taking it a little bit further from what you have said, that, at what point do we say that the response is suboptimal and should be changed? Like, what is the cutoff? Because if we look at the studies, even the assembled trial and all of these, and some of the experts, they would say that loss of MMR or not achieving MMR, right, which is a very strict cutoff point. So it's like, so what is your threshold? Like if a patient is hanging out at 0.09% or 0.05%, do you think that is no suboptimal response?
I don't think for a patient who's, maintaining a 0.09 or 0.05, I would not consider that to be a suboptimal response. Less than 1%, there is good enough data to suggest that that is a good enough response to continue on the same TKI, that same treatment regimen that you are following.
Right.
Yes, of
So
course, if there
your
is a
worry
serial.
level is around 1%. So if the
Yes.
patient is below 1%, you will probably just stick with the same.
Absolutely, absolutely. And if there is a loss of response, that would be
Yes,
worrisome.
yes. Dr. Anshul, at what response level would you say that, okay, now your patient is, we've passed the 3, 6, 12 months, 18 months. What is the cutoff that if the patient is not hitting, you will say, okay, now I'm worried, I'm going to switch. Because this is a very, very, I think as more, these have become available, we can be very trigger happy and switch very quickly.
Ma'am, I'm happy with reaching MMR and anything
Okay.
beyond that. Okay, so deep molecular response is something that we want. And unless the patient is
No, that
deciding,
is the goal. But when do we say that it is suboptimal and let's change?
so if the patient is reaching MMR,
Hmm.
I'm okay with that. And if the as Dr. Nivedita said, it is, when the patient starts to have a loss of MMR, at least, then I am concerned.
Yeah.
Okay.
Yeah.
So
So I think,
if the
okay,
patient
yes,
does
please,
not reach
please, please.
MMR, then of course, after a while, maybe after 12 months, is the maximum cutoff I'd give. And then probably I would like to, do an IRMA or repeat marrow or something.
Right, right. No, no, I think that's so there is, I think even in the practice world out there, there's a little bit of difference of opinion here because there is one school of thought saying that if you, as long as you have complete cytogenetic response, the long-term survival is pretty good and you don't necessarily need to cycle TKIs. But there's another school of thought that if your patient is not reaching MMR, then the treatment is suboptimal and it should be changed. As these treatments have become available, we are seeing patients going around, seeking opinions because somebody has told them they should switch, and another person thinks you are fine, don't switch. And the whole question of TFR then comes in. They're like, oh, but then how will I achieve TFR if you don't switch? So,
But would you be
and you have to
comfortable?
tell them that
My
you are never
question
going
to
to get into TFR. So, just you are doing fine, you are going to live a long life. So, I think that when interpreting this and advising whether to change or not change, it's become difficult. I think um, for patients to do that. I think if somebody says, I'm not happy with anything less than MMR and I'm going to switch and get them on to the next line, it's fair. If another person says that complete cytogenetic response, long-term survival is very good, I'm not switching, that is also fair. And I think that's where a little style difference can come in what we do. But these are practical. The number of consultations now where this is the question, like when to switch and say suboptimal, I think have increased as all of these things. I think this is also a rhetorical question. I think mostly anybody want to, Dr. Anshul, if you want to take this, Dr. Nivedita has already sort of said that her piece on this particular question as to how much should we be changing TKIs one after another, then go back.
So, ma'am, I'm not a very big fan of it either.
Yeah, 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 yeah,
So as
yeah.
you give the TKI enough time, and even if
Mm,
there's a loss of MMR, I'd like to give 2 to 3 months, maybe repeat it after a while. And then, still if it continues to do so, only after then, doing the entire workup again, I'd reintroduce it another TKI and then give it at
yes,
least 6 months time.
yeah. I agree with you broadly, and I think for if anybody who are in the audience, I think if we can give a limited message that it's great that we have more potent and alternative mechanisms of action drugs, and we must check. I think another thing is that you don't forget to check. You do keep an eye and see where your patient is, but you really don't have to jump the gun very quickly and change for subtle differences. This I think we have already discussed. And to some extent, I think also the fact that even if you get a response, at that point, the responses may not be durable once you're into third line treatments. because then it's probably something about the disease biology that the patient is having more cytopenias and more, and not able to take continued treatment, and also not meeting milestones. So in our country, a discussion on transplant in young patients is fair at this point. I think in a lot of places they might say that there are so many non-transplant options. Why even bring it up? Just keep going, taking them to different drug options. I think that's also something, a little bit of controversy. Dr. Nivedita has said her piece. Dr. Anshu, do you want to talk about at what point you would say that, okay, now let's start evaluating for transplant?
So, ma'am, agreed that, transplant in today's time, and there may be bias since I don't actively do transplant now. Uh, I would be, rather keen to challenge the patient if it's non-responsive for the first and second generation TKS. I would like to, probably try asciminib before I say, ki, let us go for transplant. And again, those patients are still very few in my practice.
Yeah. I think in a big question that practically comes for us is the cost question at that point. I think if asciminib comes at a price point where I think we can rescue some people without transplants. If asciminib or ponatinib become available at price points which they can continue to take lifelong. But in the way the asciminib is priced right now, transplant is a cheaper option for these patients. So I think it's also an economic decision. It would be
I
wonderful if so for 10 of those patients who are considering, maybe five you can get away without doing a transplant and rescue them with asciminib. But cost of taking this drug lifelong is going to be a very, very big challenge. So I
So
think until that
just a
happens, yes,
small
yes, yes, yes,
addition, or maybe a small query to that. So if somebody has a T315I
yes.
and is started on asciminib because of that, BCR-ABL is rising, and you see that there is a T315I, you start asciminib 200 milligram BD. Would you still, young patient, fully matched sibling donor, would you still consider a transplant in such a case, or would you just continue the asciminib for a young 40-year-old?
Yeah, so we sort of debated this exact question, but not for asciminib, but for ponatinib. I think at RGCon a couple of years ago. And I was arguing one side, Dr. Mishra was arguing the other side. Uh, and if you can find literature to support both your arguments.
Yes.
So there's enough literature saying that with T315I, with ponatinib, I'm talking about the data. If they are sensitive and they're responding, their long-term survival will be fine, and you don't transplant them. So if you want to argue that point, it is there also. But I think just the fact that it is T315I right now is not enough of an indication for transplant. I think the indication is more of a practical indication, the fact, the cost consideration of taking lifelong therapy. But if it was somebody who could afford it lifelong without any hassle, I would probably just watch their molecular numbers very closely and not transplant. But those patients are so few, because for most people it's not going to be practical to afford it. I would transplant
So,
them. I think it would be more of an economic decision. If they can afford it, I think they can do well without transplant also.
but if we look at the data of asciminib, uh, so we have very few patients, I think 50 odd patients with T315I who took asciminib. And there is emergence of mutations and new mutations on, and myristoyl site pocket mutations also on asciminib. So I
Yeah.
think,
So the
so
temptation to just
yeah, so the temptation.
yeah, yeah. No, I think it's a fair, uh, worry. Uh, you let us know what you decide eventually. I don't think it's an easy answer for that, because you also worry about the long-term comorbidity of transplant-related complications. Is the patient doing
Absolutely.
well on asciminib in terms of tolerance and
Yes, she's
molecular
tolerating it
profiles?
very well. Actually, she used to be in my outside my OPD practically every 1 or 2 weeks earlier. She had a lot of cytopenias with dasatinib.
Yeah, yeah.
And now, since I've started SMNF, I have to call her and ask her how she is, and she should come to the hospital for a follow up. But she's tolerating it very well, and she's had a major molecular response to SMNF within 6 months. Actually, the 3 month BCR ABL was only pretty good. It was, I don't remember the value, but she's doing
Okay.
quite well. She got away from a transplant initially because the donor was pregnant. So,
Ah,
and in the meanwhile, she procured SMNF, so she's doing well
asciminib.
now. Yeah.
Okay, okay. I don't know. I think no additional cytogenetic abnormalities, nothing else worrisome in the marrow where worry about disease progression. It's just the BCR-ABL.
So this question keeps bothering me whether to, just continue like this or maybe just do it once and for all and, be
Yeah,
done with it. So
yeah,
I thought,
yeah. It's a temptation. I think I'm 60-40 in favor of non-transplanting. But yeah, it's a tough one. Um, I don't know if I'm not aware of any concerns about a lot of additional mutations specific to asciminib in T315I, but we'll see. I think with time it will become clearer. Okay, I think we already discussed this. A response is obtained. So that is, the sort of the question that we were discussing about the sustained responses. Okay. So we already discussed this as well. Yes, so I think this is an important question to discuss, that we do say that it is a blessing for our patients. Then we try to tell them, oh, you're so lucky, you are just taking this pill and you are fine. But the fact of the matter is that there are low level quality of life issues. Dr. Anshul, how big of a challenge do you think the quality of life issues with TKIs are in your practice? Short term, long term?
Well, I think it is a big challenge, ma'am. So we
Yeah.
hope that the patient does not have any toxicity, but the ones who do, it's such a challenge because it's never going to stop.
Hmm.
There is the treatment duration is not finite. And
Right.
eventually, if it patients, we just ask them to learn to adapt with it, learn to live with it, but that's not
Right.
the ideal way. And in some extreme situations, we have to change it based upon, the patient's preference, that no, I'm not able to tolerate the side effect, and you please change this. But
Right.
even if you continue the same, even with imatinib being the first and the safest TKI, I think there are few side effects which are there. I remember one patient of mine, she just would have swelling around orbits and eyelids, and we
Yeah.
worked her for everything, and we just realized that this is probably imatinib induced. We stopped imatinib for a week and the swelling went down, but then the
Yeah.
patient was doing okay otherwise, so we had to continue it. And
Right.
but it's a bothersome thing. Patient says that I always seem to have droopy eyelids, so yeah,
Yeah.
it's a
Yeah.
challenge.
Right. So it's not entirely, I mean, they're low level, low grade AEs, but they're not entirely like um, not bothersome, especially for things that you have to take all the time. So hence, even when all the milestones are good and everything is good, there is always this thing. So I think if we the desire to improve upon that and come up with molecules that you can even remove these low level adverse effects is something that is desirable, and hopefully eventually these well tolerated newer molecules will come in first line as at an affordable rate, because toxicities also and long term safety wise also it will give us additional things that we can give to these patients. So, this is, we don't have a lot of long-term data from trials, but in, I think, our practices, we do have some patients who've been taking TKIs for over a decade. And we can see that there are some cumulative toxicities also. The skin changes, hair changes, chronic GI issues. You can tell, I think, looking at a hospital waiting room, which patients are on a TKI because pigment changes, all of those things do happen. And I think as these patients live longer, concern for these also becomes important. And sometimes in a setup where you have large volume of patients, you may not be able to spend a lot of time counseling each and every patient, and they might just stop treatment, right? Because of these side effects. So which just not adherence due to low level quality of life issues is also eventually going to lead to a survival disadvantage for these patients. So we know about the TKIs that are currently approved and available for second line and beyond: nilotinib, dasatinib, ponatinib, and bosutinib. The for the assemble study, it was compared against bosutinib. Any comments on,
Dr. Isha, ma'am, great presentation, but you have another 5 minutes to conclude, ma'am.
Oh,
Excellent.
I'm happy to conclude. I think, believe me. So I think this is data. That's why I'm like going off script here and discussing more other things. So what is your thought? Okay, Dr. Nivedita, will come to you. Uh, about bosutinib as a comparator, to, I think, nilotinib, dasatinib, we know we've used that a fair bit, so we understand the toxicities and the issues with that. How do you place asciminib versus bosutinib?
So, bosutinib, I actually, for both the drugs, I have just one patient each that I have used it personally. But bosutinib does cause pretty bad diarrhea. So I had to place an elderly patient on bosutinib because he was not tolerating any of the TKIs. And at that time, asciminib was not available. And he kept having on bad diarrhea and eventually had a cardiac event. He was an elderly patient. Asciminib, from what I've seen from one patient's experience and what the trial data mentions, so in general, the rate of treatment discontinuation was much lower with asciminib. So it seems to be more well tolerated. And the point that you were previously making about, low level adverse events. So we did have a
Right.
thesis in AIMS where up to 30% of the patients actually discontinued. They had poor treatment adherence because of those low level adverse events. So they are not as insignificant, as we
Correct.
sometimes tend to be towards
Tend
them.
to believe, yes. Yeah. Yeah, I think bosutinib is just a terrible drug. Uh, and given a choice, I would not. I mean, I would. That is, if bosutinib is the only option left, I would transplant the patient. Um,
I hope the bosutinib company, guys, I hope Novartis is not making bosutinib.
I don't care. It is a fact. It's a
I
toxic
agree.
drug.
I agree. It
It's a
was terrible.
toxic drug. If somebody has to take it for a short duration, you can somehow get through it. But I can't imagine putting a patient through a lifetime of taking bosutinib. It's just terrible.
So
And
now we
so,
have nilotinib generic. I think that is much more well tolerated, although it has
exactly.
twice.
I agree with you. I think so. In that sense, I think asciminib is definitely superior to bosutinib in terms of, the study shows it. But in general, I don't think we need a lot of convincing to say that asciminib is better than bosutinib. We can very clearly agree that it is, whether efficacy or tolerability, both ways, it's a much superior drug. So the I think we can just conclude on this slide that we have now almost 5 years of experience with asciminib, showing its superiority when compared to bosutinib. Like I said, agreed. Definitely, it is better than bosutinib. No questions there. The safety profile is pretty good. It's pretty good. Some cytopenias there, but still quite not such a big problem, because this is also the line of the setting of two or more failures. So sometimes just in this situation, people will get, when you look at disseminate upfront data, the true safety profile comes there, which is also quite good. Not a lot of concerns there. And we I think it's a good drug. It's just it is a very important tool. We have something even with ponatinib for T315I. The issue of the vascular toxicity is something that bothers us and we worry about. So I think having another option for T315I for patients with cardiac issues or vascular issues or hypertension, a non-ponatinib option would be a great option. And I just hope that we can find mechanisms of making it available to more and more people. Otherwise, it's just a very good drug that most people can't afford. Dr. Anshul, any closing remarks from you before we give
I
it
think
back
I
to the
think
organizers?
very much the same, ma'am. That in these situations, I would also, I'm not used Bosutinib, but I've heard enough to, figure out that.
When the initial bosutinib trial was happening, I was a fellow. It was terrible.
So I'm thinking that was we're glad that Asciminib is here, so to rescue those patients. And I think that point of yours with respect to transplant, when being a cost-effective way, I think that's well taken. Uh, So with that, I think I agree with most of it, whatever you have said. That Asciminib is better than Bosutinib, of course. We've got to use it as a reserve drug. Increasingly, let's see how the data evolves, and as the cost comes down, probably it can come in a little bit of frontline.
It's now approved frontline.
Now, that's what I'm saying,
FDA is
ma'am. So
approved.
we're not discussing
I
about
don't know
it
what,
because
I
of
think that maybe it's the future of CML.
yeah.
I think I
But the
get a lot
cost,
of brownie
no, but
points
the
from
cost part
Novartis.
is there now. But the cost part is there.
I think if frontline, if they can long term show in some way, shape or
Yes.
form that the patients can get TFR, that will make the case. But otherwise, it's pretty hard to beat what
Yes.
we have already. I think it's
Absolutely.
all right. Thank you so much. Thank you so much to my wonderful analysts, and I give it back to the organizers.
Thank you, Dr.
Thank
Isha.
Thank you, ma'am. Thank you for the wonderful presentation on Asciminib and its role in CML. It was very enlightening to hear the conversation you guys had. And thank you, Dr. Anshul. Thank you, Dr. Nivedita. And for the next presentation, I would like to call upon Dr. Nikhil Kumar from FMRI. He's a consultant hematology and BMT department there. He would be sharing his experience in the Indian scenario for CAR T cell and the role in the B cell malignancies. Over to you, Dr. Nikhil.
Thank you for the kind introduction. I'll just share my screen. I think there is some issues. My screen visible?
No, sir. If you allow, can I share some?
Just give me a minute. I'll try
No
once
problem.
more if it's not
So
happening.
by the time Dr. Nikhil is trying to figure out this technical glitch, I'm Dr. Bhargav, and Dr. Nikhil is spearheading our myeloma vertical at this present moment of time. And he has got a fair experience between the teclistamab and the CAR T cell, so he will be able to elucidate that the timing of the CRS between the two. It's still not shared, Dr. Nikhil. So it's a very great evolving field. And the last week, US FDA has approved CAR T cell as a frontline therapy after 2 cycles for high-grade B cell lymphomas. So I think it's a great and wonderful time that we are there and learning new things as we have indigenous CAR T cells which are working pretty well at this present moment of time. And yesterday also we have infused one of the patients with the CAR T cell, and this week we are going to do that. So over to Dr. Nikhil, who can tell us virtually hour by hour condition of the patient and how to manage in that complicated stage. Is Dr. Nikhil there?
Yeah,
I think he's trying to
is
figure
my
it out.
screen visible?
Yes, sir, perfectly.
Perfect. So we'll get
So
going.
over to you, Dr. Nikhil.
So today we would discuss some of the treatment considerations for patients who have failed first-line treatment in BNHLs as well as BALL while reflecting on the real-world data in the context of NextCar19. So we are all very familiar with this algorithm. Newly diagnosed DLBCLs, almost always, R-CHOP remains to be the treatment of first choice, with around 60% of patients achieving a cure and doing well after 5 years. But the remaining 30 to 40%, 10 to 15% patients tend to be primary refractory, while a good 20 to 30% relapse, mostly within the first 2 years. And in both these groups, especially the primary refractory ones, the outcomes have been dismal, especially those patients who relapse in the first 2 years. So this pie chart kind of sums it up, where a quarter of the patients still relapse or are refractory and require better treatments. So the question is, what do we do with patients who relapse early in their treatment course, which directly indicates they're refractory to most chemotherapeutic agents as compared to patients who relapse after a year? Obviously, in our setting, treating these patients is an uphill task, and the path is going to be filled with potholes. Cost is an important consideration, and so is the treatment toxicity. So, coming to the efficacy data, we are all familiar with the PERMA trial, which showed superiority of autologous stem cell transplant as compared to salvage chemotherapy alone, where patients who received salvage followed by an autologous transplant had a significantly better event-free survival and overall survival. But in recent years, many salvage treatments have come up, and there are few studies which have compared them to each other, like the Coral trial, which looked at RIs versus RDAP, followed by a transplant, provided patients achieve at least a partial response. And there was no significant difference between the two regimens. Similar was the case with RGDP when it was compared with RDAP. Again, no significant difference in efficacy, but obviously the toxicity profile was better with RGDP. Attempts have been made at replacing rituximab with ofatumumab. Again, no significant benefit was noted. And as you can notice, the EFS and 5-year OS is somewhere in the tune of around 40%, even with the best available salvage therapy followed by an autologous transplant. So, did CAR-T change this equation? The answer is yes. Starting from the ZUMA-1 trial, where more than one quarter of the patients had DLBCL and more than 70% of the patients had received at least 3 prior lines of therapy. As you can see, the overall response rates were significant at 82%, with more than half the patients achieving a CR rate. Toxicities were a concern, with around 10% of patients having severe CRS and neurological toxicity noted in 1/3 of the patients. In Juliet trial, where Tisacel was given and followed by a bridging chemotherapy, again, patients were refractory to multiple lines of therapy, with most patients receiving median of 3 prior lines of treatment. The response rates was around 50%, with around 40% of the patients achieving a CR. In the Transcend trial, where Lisocel was compared with the standard of care, again in patients who are multiple refractory to treatment, the overall response rate was impressive at around 73%, with more than half of the patients achieving a CR. The 2-year PFS was around 40%, and the overall survival was 50%. So while all this Western data was still available with us, we still were lacking an indigenous product which could be easily applicable to our patients. NextCar19 has kind of changed this equation. Though we do not have long-term PFS and OS data, and I think this year it is going to be presented at ASH, but the short-term rates are pretty impressive, with the 3-month CR rates of 50% and an overall response rate of 68% in patients who have failed multiple lines of treatment. What are the other options in patients who really cannot get to a CAR-T because of either logistic reasons or non-availability of CAR-T? Multiple agents have been tried, including polatuzumab and tafasitamab. Pola-BR in a phase 2 trial showed response rates of somewhere around 40%, with cytopenias, peripheral neuropathy, and neutropenias being the most common toxicity. We are familiar with the L-MIND study, where they showed that a combination of tafasitamab with lenalidomide given for 12 cycles had a CR rate of around 43% with overall response rates of 60%. The median overall survival at 1.5 years for this multiply refractory patients was around 64%. Bridging therapy was allowed in both studies of Lisocell as well as Axicell in the Alcante as well as a pilot study respectively, where the overall response rates were quite impressive at more than 75 to 80%, with more than 50 to 60% of the patients achieving a CR. The toxicities of CRS and ICANS were similar in these trials. So this is a comparison of the landmark trials which have looked at using CAR T cells in the second line setting, enrolling a good number of patients. What I would want to draw your attention to is the fact that while majority of the patients enrolled for these trials could proceed to a CAR T because achieving a partial response was not a prerequisite for CAR T cell therapy, only patients of 30 to 40% of patients receiving a second line therapy could effectively proceed to a transplant. The issue always remains that the median duration from registration to apheresis for CAR T cell to a CAR T infusion is at least around a month, and hence a bridging treatment is required to at least make sure that the disease burden gets controlled, if not trying to reduce the disease burden, as we know that the complications of CAR T like CRS and ICANS are directly proportional to the disease burden. What are the other options available? Multiple other agents have been tried, like the POLAR GEMOX trial from the POLARGO trial. The CR rates and overall response rates roughly to the tune of 40%. In those patients who either cannot get to a CAR T or even relapse post CAR T, glofitamab has been a promising treatment, showing around half of the patients showing a response with a CR rates of roughly 40%. 1.5 years was the overall survival, and the median duration of CR was around 2 years. Ibrutinib-based therapies have been tried in these group of patients with treatments like rituximab, lenalidomide, and ibrutinib, which we commonly use for our refractory patients. But the response rates, as you can see, are to the tune of around 30 to 40%. Different combination of BTK inhibitors have also been tried in this setting, both as monotherapy and combination therapy with standard protocols like RIs, where the overall response rates have been impressive at around 80 to 90%. But the follow-up duration was relatively short, and the PFS and overall survival rates are around 40 to 50%. Can venetoclax be tried in these patients? Yes, few trials have looked at this data with the VIPOR regimen, where the CR rates was around 30 to 40%. Again, the 2-year PFS and OS hovering around 30%. One criticism that very often comes up before taking patients for CAR T cell therapy is that it is a very costly affair, which is out of reach for more patients. So let us look at whether that fact even stands now. Nexcar 19 with their patient support program, the product is available for 30 lakh rupees. And even if you compare it with 2 to 3 cycles of salvage therapy followed by a transplant, the cost would come to a similar figure. So overall cost, including the cost of supportive treatment and the cost of hospitalization, would somewhere come to around 40 to 50 lakh rupees. Whereas depending on the complications that patient has and depending on the number of salvage cycles and hospitalization for reasons like febrile neutropenia, the cost of salvage followed by an auto transplant can widely vary, anywhere between 20 to 40 lakh rupees. So I think with time, once the CAR T products become cheaper, the cost would be very similar to taking patients through a salvage chemotherapy followed by an autologous transplant, which is again available for only a set of patients who are able to get into a PR or better with salvage chemotherapy. So this definitely is a promising therapy, especially for patients who relapse within the first year or are primary refractory to chemotherapy. And the other regimens, including Pola-BR and Pola-R GEMOX, if we include the cost of supportive care, is significantly more expensive. And glofitamab therapy, needless to say, including cost of obinutuzumab, which has to be given prior to reduce the risk of CRS, and the cost of importing the drug is prohibitively expensive. So considering the fact that CAR T cell is a one-time treatment with a fixed cost, if we are able to take the patients to CAR T, would still be a better and probably cheaper option than glofitamab and other products which has to be still imported. So I'll not go over this, but considering the treatment paradigm, I think this is well established that patients who have an early relapse within the first 1 year and are eligible and are able to get to a CAR T cell should definitely be considered as the treatment of choice in these patients. And in those patients who relapse after a year and are eligible for autologous transplant and who respond to salvage chemotherapy and achieve either a PR or better, patients can be considered for autologous transplant, keeping CAR T and other options for subsequent relapses. Is there a role of maintenance therapy? We still don't know, but there are a lot of trials which are ongoing in this space where this option is being explored for high-risk patients. Coming to the domain of acute lymphoblastic leukemia, again from the international data, both from the Iliana and Zuma-3 trial, Tisacel had an impressive overall response rates of 82% with a median EFS of 24 months. While in the Zuma-3 trial, Brexucel at a median follow-up of 26 months had an overall response rates of around 70% with a CR rate of more than 50%. The median duration of response varied anywhere from 14 to 18 months, which necessitates that most of these patients have to be consolidated with a allogenic transplant. Again, coming to NextCar19, we don't have mature data yet, but in those patients who are refractory to treatment and received a CAR T, the overall response rate at 3 months was around 70%. The cost of treatment would be slightly higher considering ALL patients would require more hospitalization and the cost of supportive care, but the overall cost would vary somewhere between 40 to 50 lakhs, while salvage chemotherapy followed by an allogenic stem cell transplant would still be cheaper if we exclude targeted treatments like blinatumomab. Since getting patients to an MRD negative status is a prerequisite for allogenic transplant in B-ALL, most of these patients would end up requiring either inotuzumab or blinatumomab as part of a salvage chemotherapy regimen, thereby significantly hiking up the cost. We are all familiar with the toxicities as more and more CAR T products are being infused. CRS and ICANS has been significantly reported in all the international trials, with more than 67% patients having CRS, and the rates have been somewhere between 40 to 80% considering the different CAR T cell products. With NextCar19, no significant grade 3-4 CRS was observed in the lymphoma cohort, while in patients with acute lymphoblastic leukemia, around 20% of the patients had grade 3 CRS. What would be the difference compared to, let's say, bispecific or anything? Typically, in our experience, patients usually develop CRS after 2 to 3 days. The immediate peri-infusion period has not been problematic, but the CRS as well as severe reactions that we have noted have been after 72 hours. And I would like to know the opinion of the other esteemed panelists and discussants also today. But by and large, no incidence of ICANS has been reported yet with NextCar19, both in the lymphoma as well as leukemia cohorts. This is in stark contrast to many of the other CAR Ts like Lisocell, where a significant proportion of patients had neurotoxicity and around 10 to 15% had serious or grade 3 neurotoxicities reported. So the toxicity incidence in the real world has been very similar to what has been reported in the initial data. ICANS incidence, though it has not been reported, but it remains to be seen that in patients with active CNS disease, whether there would be significant ICANS. So while longer follow-up data with a larger cohort would be required before we can ascertain the toxicities with the indigenous CAR-T, the initial data looks promising with no severe CRS reported in patients who received CAR T cell for lymphoma, while less than a quarter of patients had severe CRS in patients with ALL and high disease burden. Can we reduce the toxicities? Again, a lot of research and a lot of trials are looking at this. But in our experience, even in patients with high disease burden, prophylactic tocilizumab 1 hour before administering CAR T has been helpful, at least in the immediate period, to reduce the incidence of severe CRS. With that, I would end my talk. I would thank the ImmunoAct people for giving us this platform, and I would be happy to take questions.
Thank you, Dr. Nikhil. Thank you for the wonderful talk. As a medical oncologist, who obviously we don't do CAR T and transplants both, it was very nice to know the cost of this treatment has come down and it is practical enough. As you said, we used to imagine it is robustly expensive. But yeah, it's an effective therapy, as you mentioned, and is available now. So very nice to know. Thank you for the wonderful talk, sir. Um, so
Thank you.
for the next session, if there are no questions, any questions, please?
A question from our side, actually, from ImmunoAct side. Um,
Yes.
as a drug company, we've always been trying to make sure that we can broaden access. And in the context of real world, so there are a couple of registries that have used their own CAR T cell therapies in real world. One is, of course, the Descartes registry or the Descartes registry in France. There's the CIBMTR registry in the United States. There's also the ROCA registry in the United States, and recently there's been a publication from the Leuven registry in Belgium. The question is that in many of these, Tecartus and Yescarta had an early apheresis program. Do you think that in the Indian context, there would be a higher frequency of their potentiated requirements, specifically when it comes to high risk patients in the first line failure, wherein you would still want to try another therapy, but you may want to apheresis the patient first and cryopreserve their lymphocytes, just so that if a potential CAR T is required, then that can be availed. And the reason that we ask is because unlike the other CAR T cell therapies, our dose is much higher. We have to go to an efficacy dose of 5 million CAR positive T cells per kg, which means that we really need a good T cell subset to begin with. So that's the question in the lymphoma context and in the persistent MRD BALL context.
I think that's a very good question, because as we go along and we have more and more genetic data coming in to see who would respond to the initial chemotherapy and who won't. So in those patients whom we anticipate that there is a high chance of treatment failure, I think that would be definitely a viable option, because once we treat the patients and they are heavily pre-treated, sometimes getting the adequate dose or the adequate lymphocyte by apheresis may be a challenge. So going forward, I think this is something which can be considered where, let's say, patient has a TP53 mutation, patient has high risk of treatment failure. They probably can get their product cryopreserved before going on with further therapy, which may make apheresis down the line difficult. So yes, I think there is a possibility that this could be an option which could be considered in the Indian setting.
If you could put a percentage on each of these, and also if you could let us know like the average window by which you would want to wait after apheresis. And the reason that we say that is because we'll try and generate some data from real world samples of early leukapheresis products and their preservative capacity to be expanded into CAR T.
Yeah, so in the lymphoma space, we still don't have an accurate idea of who would respond to the treatment and who won't. But at our center, we have been doing NGS on the lymphoid tissue for all the patients upfront. And while it is, let's say, very premature to comment on it, but we have seen that in patients with mutations like TP53 at baseline, the response rates are typically lower. So I would say in the lymphoma space, let's say with a typical DLBCL, before we could say no, 70% of the patients would respond, 30% won't, and we do not know upfront who's going to respond and who's going to not respond. But with more and more data and more of genetic data available with us, we very well know that at least 15 to 20% of the patients, and definitely patients with a high incidence of high risk mutations, may not respond. So I would say the data would be somewhere around 15 to 20% in the lymphoma space. And ALL again is a very heterogeneous disease where we very well know with high risk mutations by the end of first cycle, let's say if they are MRD positive or if they have refractory disease, chances are they are going to require a CAR T cell in the future. So this again would be somewhere around 20-25%. Now coming to when should we collect the product, when should we do the apheresis for lymphocytes? I do not know what the data suggests, but in a lymphoma space, let's say after 3 cycles, if there is no adequate response, probably that would be a good time to do it. And while for acute lymphoblastic leukemia, again, after the first line of standard treatment, before we go on to a salvage chemo or more toxic therapies, probably this can be considered. But I think from Immunoact side, you would definitely have a better data set for this, at least from your experience in TMH and other centers. So what is your take on this?
So our take is that at least in the TMH setting, in the real world setting, a lot of persistent MRD after the first 2 cycles of induction, who have shown a persistent MRD and sometimes even a blast presence beyond the marrow, they have been taken up for CAR T. But in that case, they've immediately been apheresed with the intention of bridging and taking them on to CAR T. Now, in the global context, this is very different. And of course, in the real world context, we're waiting for the real world data to mature to an extent that lets us know whether it is really beneficial in the long term context. So I guess our response would be that we would have to wait and see. But that being said, in the other context of CAR T cell therapies, which have been globally used in those registries, the growing paradigm has been apheres with the intent to manufacture after 2 lines of treatment and then either immediately give CAR T or give it later. There was a study in the British Journal of Hematology that was published last year, which in which such a retrospective study, prospective study with an early apheres cohort, early treated cohort versus standard apheres and then later treated cohort. The early apheres patients who then received another therapy had an increased number of PR on a propensity analysis. So that would probably, assumedly, allow for a couple more options for a follow-up therapy. But what it remains to be seen in India is a matter of time.
So that's wonderful.
But again,
So basically, what you're trying to say is,
So Dr. Nikhil, I'm so sorry to interrupt. We're running short of time. So
no problem.
can we go to the next session, if you permit, Dr. Ishu Gupta, sir? Would you invite the next speaker, please?
Yeah,
Excellent talk and excellent discussion, but I think we are really short of time. So Ishu, sir, all to you.
Thank you. Thank you.
Thank you, Dr. Nikhil. As interesting it was, as more we would like to have heard you, but again, time is a limitance here. So for the next session, I would like to call upon Dr. Chetan, who is from Kidway Institute of Oncology from Bangalore, and he would be discussing on the developments and the management of high-risk multiple myeloma. Thank you. Dr. Chetan, are you here? Yeah.
a minute before
Hello, Dr. Chetan. Hello. Hello, Dr. Chetan. Can you hear us?
Yeah. Oh, a minute before I share the slides.
No problem. No problem. Take your time. No problem. Any help required from our side or from the technical team?
No, I am done. I'm just sharing.
Thank you.
Hi, good evening, all. Am I audible? Hello.
Yes, sir.
Yes, sir.
Yeah. Thank you for the organizers for giving the opportunity. I will be talking on the role of daratumumab in patients in of multiple myeloma. I'll just go through some of the evidence on daratumumab in both patients who are newly diagnosed multiple myeloma and patients who have already received some form of treatment for multiple myeloma. The first trial which showed the benefit of using daratumumab in patients with multiple myeloma who are newly diagnosed and are eligible for autologous stem cell transplant was Maya study. In this study, what they compared was the daratumumab with the backbone of len and dexa was most of the patient in this study, most of the patients were more than 75 years of age, and I have all the risk groups was evenly distributed between the two arms. As we see, this study demonstrated an improvement in progression-free survival in the DRD arm as compared with the RD arm. The median PFS had not been reached in the DRD arm and was 39.1 months in a RD arm with a hazard ratio of 0.56, that representing a 44% reduction in the risk of disease progression or death in patients treated with DRD. If we see the responses compared with the DRD with RD, stringent complete response was in 30% of the patients, compared to only 12.5 patients in RD arm, and both CR or better response was around 47% in the DRD arm and 24% in the RDM. What was impressive was VGPR or better response was in around 80% of the patients, but it was just 50% in patients with the RD arm. MRD negativity rate was also higher. It was around 90% compared to 27% in RD. which are all statistically significant. The next trial, which compared daratumumab with the backbone of bortezomib, melphalan, and prednisolone in patients with newly diagnosed multiple myeloma. The other arm was bortezomib, melphalan, and prednisolone. In this trial also, daratumumab showed higher efficacy compared to bortezomib, melphalan, and prednisolone. MRD negativity was around 70, 40, 50% in this compared to 25%, which was less than the previous trial, MEIA trial, which demonstrated that lenalidomide is integral in the management of multiple myeloma. The recent trial that showed a benefit in patients who are eligible for autologous stem cell transplant was Cassiopeia trial. In this trial, they compared daratumumab with bortezomib, thal, and dexamethasone. In the outcomes, what they saw was stringent complete response rate at day 10 post transplant, complete CR at day 100 post transplant, and progression free survival. First line use of daratumumab in patients with autologous stem cell transplant showed showed higher rate of stringent CR when compared to the VTD arm. After a median follow-up of 18.8 months, median PFS had not been reached in either arm. However, adding daratumumab to VTD resulted in a reduction in the risk of progression or death by 53% compared with the VTD alone. Next, coming to the use of daratumumab in patients who have received at least one prior therapy for multiple myeloma. In the Pollux trial, they added daratumumab to the len and dexa. If we can see, at least median lines of therapy received in these patients were at least one. 60% of the patients had received earlier ASCT, and 86% patients have received some form of proteasome inhibitor, and 55% had received len. Refractory disease was around 27%. In the last line of treatment, they have received, and 18% and 21% were proteasome inhibitor resistant refractory diseases. Stringent complete response was around 20% compared to the 7% in patients without the daratumumab arm, and median time to response was around 1 month in both the arms, and median duration of response had not reached in patients who are in daratumumab arm. However, it was just 18 months in non-daratumumab arm. In the Castor trial, they compared added daratumumab to the BOTI and DEXA backbone. In these, the results were almost pretty similar, and PFS was around twice in daratumumab arm compared to the non-daratumumab arm. In Candor trial, they compared added DARA to carfil and dexamethasone. The results were not much different in both the same compared to the previous trials. However, one question that arises is whether daratumumab, what is the effect of daratumumab in patients with high risk cytogenetic factors? We all know multiple myeloma patients with specific cytogenetic abnormalities are at high risk of poor outcomes, and IMWG recommends defining high risk cytogen as testing positive for more than one of the following abnormalities, like translocation 414, translocation 416, or deletion 7p by FISH. In all the trials that have used daratumumab, there is no uniformity in defining the high risk cytogenetic. Previous trials have used all three cytogenetic abnormalities. However, Cassiopeia used only 414 and 416. and these studies have not compared the association of daratumumab with PFS among patients with specific high-risk cytogenetic abnormality, and no study has compared OS with the OS association with the specific cytogenetic abnormality. This slide shows the benefit of adding daratumumab in newly diagnosed multiple myeloma. If you can see, the forest plot shows the benefit of using daratumumab in all the subgroup of the patients in high risk patients. In this slide, this slide also shows in the forest plot also shows the benefit of adding daratumumab in relapsed refractory multiple myeloma in these patients also in high risk group. In a meta-analysis that pooled all the patients who had received daratumumab in these 6 studies, we can see that median PFS was better in patient who received daratumumab. This is a forest plot with showing benefit of adding daratumumab in all the 3 studies in high risk multiple myeloma and standard risk multiple myeloma. So what are the key limitation of meta-analysis is individuals. These meta-analysis pools results from the individual studies and shows that similar to trend noted in the individual studies, addition of daratumumab to standard of care regimen suggests an improved PFS. It is important to note that meta-analysis does not provide comparison between daratumumab based and non-daratumumab based regimens in high-risk multiple myeloma. One thing that is to be noted is these meta-analysis has shown that the addition of daratumumab does not abrogate the prognostic impact of high-risk cytogenetics in both newly diagnosed multiple myeloma and relapsed refractory multiple myeloma. Thank you. Hello.
Oh, sorry, I think, muted. Thank you, Dr. Chetan, and thank you for the wonderful discussion on role of daratumumab in multiple myeloma, especially the high-risk ones. I guess it's a wonderful drug which has changed practice for a lot of hematologists, and we are yet to use it much as medical oncologists. Uh, so for the next session, moving on to the solid medical oncology updates, we would call upon Dr. Anshul. Dr. Anshul is a dear friend, and he would be speaking on the early treatment intensification in metastatic hormone-sensitive prostate cancer. Dr. Anshul, are you here? Mm, can someone remind him?
Summer, can we call Anshul Gupta, sir? Sir is there. Sir, you are muted. Anshul Gupta, sir, you are muted. Summer, can we call, sir?
Yes, ma'am. Yes, I'm calling.
Yeah.
Thank you.
Please call. I think it must be, yeah. If not, if Dr. Ashish is there, we can start with Dr. Ashish, sir. Just check. Dr. Ashish, you're there, sir?
Yes. Yep.
Okay. So I will hold on to Anshul's talk and go on to the next talk. That is on the current treatment approaches in metastatic urothelial cancers. Dr. Ashish, my elder brother, and also somebody I look up to a lot, is going to go on for it. Dr. Ashish.
All right, all right. Just. Yeah, Dr. Ashish, sir, can we request you to start your presentation if it's okay with you? Great.
Yes, yes. Once.
Okay, I'm so sorry, yeah. Sorry to, jump in, Ashish. I was right here, just was
Acha,
on the call.
acha. Yeah, yeah.
No, please
Yeah, no,
can go
Anshul,
ahead.
Anshul,
Can go
please.
ahead.
No, no,
I
no.
can
Arani,
reconnect.
Arani, no, no, no. Anshul, please, please, please go ahead.
Are you sure? You're perfect with that? I'm okay. I'm okay otherwise. It's just on a call, so I've just muted this thing. Okay, so can I share my slides?
Yeah.
Perfect. Okay, so I hope it's visible and moving to.
Yes, sir.
Perfect. Okay. So we'll be talking about early treatment intensification in metastatic hormone-sensitive prostate cancer. And thank you once again, Dr. Ishu, and thank you, Bayer Pharmaceuticals, for offering me this opportunity. So this is the standard disclaimer. So this will be our content. So we'll be talking about introduction, then the treatment landscape, then intensification, and finally to the conclusion. So prostate cancer landscape. So, initially most of the prostate cancers, all of them for that matter, are hormone sensitive, and eventually they turn into castrate resistant, which some of them initially are non-metastatic CRPC, but eventually everybody becomes metastatic CRPC. So there are various treatment algorithms and protocols for the same. So for non-metastatic hormone sensitive, we wait and watch is also an option. Radiotherapy, surgery, ADT alone, or first generation anti-androgen virility are the standard options. With metastatic hormone sensitive prostate cancer, as per the charted in the Stampede trial, docetaxel plus ADT or abiraterone plus ADT as per the latitude are one of the options. Apalutamide as per the Titan, enzalutamide as per Arches, and a triple combination as per Peace One and Aerosense is also approved with abiraterone and darolutamide respectively. And when we come to the very small niche of non-metastatic CRPC, darolutamide, apalutamide, and enzalutamide all are approved. And as we all know, in metastatic CRPC, AR receptor pathway inhibitors, alpha therapy, PSMA targeted therapy, immune checkpoint inhibitors, chemo, and palliative care are the various options. So, metastatic hormone sensitive prostate cancer can be defined as de novo or recurrent following local primary therapy. So, patients with MHSPC can be classified as either de novo or recurrent, and de novo or recurrent disease can be based on country specific guidelines based upon PSA screening. And recent evidence, it suggests that the incidence of patients presented with de novo HSPC is rising in the United States. So coming to this, so what the extent of the disease progression informs the treatment decisions and the patient outcomes. This is TNM staging, wherein T3 is extraprostatic extension, T4 is if it involves the additional structures such as seminal vesicles or the rectum, bladder, levator, and eye muscles. M1A is non-regional lymph nodes, M1B is bone, and M1C is the other tumor sites. So then there are other classifications, is the volume and the risk used in various clinical trials. So high volume versus low volume. Charter defines high volume as at least one of the following criteria: four or more bone mets with at least one outside the pelvis or the column of the axial skeleton, or visceral mets. And high risk versus low risk as per the latitude and Stampede is defined as: high risk is defined as three or more bone mets, visceral mets, or Gleason score of more than 8, any of the two criteria at least. So extending survival, delaying progression to metastatic CRPC, and preserving long-term quality of life are key goals. To prolong OS, metastases are associated with high lethality. Of course, prolonging OS is important, but so is quality of life. Delaying progression is also one of the goals, and preserving good quality of life is. So the standard of care in metastatic hormone-sensitive prostate cancer has evolved to combine ADT with AR inhibitors, either abiraterone or docetaxel. So if you have a look here, that 2014, the chartered had docetaxel plus ADT arm. Then in Stampede, Arm C had docetaxel plus ADT. Latitude had abiraterone plus ADT. Stampede Arm G had abiraterone plus ADT. And then came the Arches Titan, where the newer molecules, apalutamide and enzalutamide, had this, and then Enzamed, wherein the triple, as well as the piece one, wherein the triple therapy was used. And then there was in 22 Erasense trial, wherein darolutamide plus ADT plus docetaxel was used. So, despite the treatment with ARPIs plus ADT or docetaxel plus ADT, a large proportion of the patients with metastatic hormone-sensitive prostate cancer will progress to CRPC within 2 to 3 years. So these are the NCCN guidelines for prostate cancer. And if you see for patients who are having uh, castrate-resistant prostate cancer with a PSA doubling time of less than 10 months, darolutamide is a category 1 indication. For patients, who are going for systemic therapy for gastric sensitive prostate cancer. If you see for the patients who are metastatic, again darolutamide along with abiraterone are the category 1 options here. So what are the clinical studies in metastatic hormone sensitive prostate cancer? So chartered trials, Stampede Arm C, Titan Arches, Peace One Latitude, the Stampede Arm G, AeraSense, AeraNote, and the Enzamet one. So this is grossly a cross trial comparison of the same. So I think this is too much of a slide. We'll move on to the next one. So yeah, if you see that the median PSA was here, was less in all of them. Then if you look at the study design, I think we'll just skip all of this. So this is just cross trial comparison. Yeah. So standard of care in hormone sensitive prostate cancer continues to evolve to early treatment intensification by combining androgen receptor inhibitor and ADT with docetaxel to further improve the survival. There are 3 trials in that, the Enzamet, Peace One, and the AeraSense. Enzamet includes enzalutamide, ADT, and docetaxel. Peace One includes prednisolone, ADT, and docetaxel, and AeraSense includes docetaxel, darolutamide, and ADT. So if you see the primary endpoint was OS in all of the 3. When we look at the outcomes or the baseline characteristics to start with, they're fairly similar across the trial groups. OS, if you see, the hazard ratio in Enzamet was 0.9, it was 0.75 in PIS1 and 0.68 in AeraSense, and time to CRPC was the highest again in AeraSense. So early treatment intensification in hormone-sensitive prostate cancer. So, AeraSense was the only study prospectively designed to investigate the combination of darolutamide AGT with docetaxel in hormone-sensitive prostate cancer. So, it randomized patients with metastatic hormone-sensitive prostate cancer to 6 cycles docetaxel followed by darolutamide plus ADT, uh, vis-a-vis placebo ADT and 6 cycles of docetaxel. And the final analysis was conducted after 533 deaths, with the primary endpoint with being the OS. So the first cycle of docetaxel was administered within 6 weeks after the start of the study drug at the discretion of the investigator. So Peace One was not prospectively designed to investigate the combination of these 3 drugs. And it's an open label study with 2 into 2 factorial design that was only conducted in the EU. So it was amended to allow for evolving standard of care with docetaxel later on. So darolutamide is the only ARPI prospectively tested and proven in combination, darolutamide plus ADT, to prolong survival and delay disease and pain progression for patients with de novo and recurrent metastatic HSPC. So this you can see darolutamide plus ADT plus docetaxel has a better survival as compared to the placebo arm, with the 48-month survival, 63 versus 50%, and the median being 48.9 months, and it was not reached in the darolutamide arm. So with the addition of darolutamide, 4-year survival rate increased from 50 to 63%, as I just said. So validity of early treatment intensification with the combination supported by results from Peace One. So again, the abiraterone plus prednisolone plus ADT plus docetaxel arm did better as compared to the control arm. Overall survival, okay, with the risk reduction of 25%. However, unlike in Peace One and AeraSense, there was an early separation in the Kaplan-Meier curve, and the lines have been separated over time. However, in this particular trial, the lines, they started separating only after 1 year. So patients in the darolutamide eye stayed on for treatment for more than 2 years, longer than the patient with placebo arm, and a similar discontinuation rate due to AEs. Again, darolutamide did not affect the ability to complete full 6 cycles of docetaxel. Okay, and yeah. So incidence of any grade events was similar in both the arms. Grade 5 were very less in both the arms. So in era sense, the incidence of adverse effects of events was generally similar again between the two arms, and incidence of rash and hypertension higher in the darolutamide arm than in the placebo. So in piece one, grade 3 or more adverse effects were higher in abiraterone, prednisolone plus ADT docetaxel arm, with additional risks of severe hypertension and hepatotoxicity. All grade adverse effects have not been reported for piece one. Severe adverse effects were higher in the abiraterone arm. So while we take a closer look, the distinct mechanism of action for darolutamide and docetaxel have a potential synergistic effect, which of course enhances the clinical benefit. So docetaxel is a microtubule inhibitor and darolutamide is an androgen receptor inhibitor. So in vitro and vivo studies have shown that targeting the AR with ARI enhances the efficacy of cabazitaxel, and abiraterone is a ARPI that inhibits CYP17 inhibition. So they work in a somewhat synergistic manner. So it's indicated for the patients of for the treatment of patients with metastatic HSPC in combination with docetaxel, and is associated with minimal warnings and precautions. So unlike abiraterone, there are no mineralocorticoid excess, adrenocortical insufficiency, hypoglycemia, or hepatotoxicity. Of course, there's a some concern regarding the seizures. However, that's very minimal. And warnings and precautions associated with abiraterone acetate and prednisolone. So cardiovascular diabetes, hepatotoxicity, adrenocortical insufficiency, and there are other metabolic issues. So yeah, basically, even in my practice, I'm a bit wary of using abiraterone, even in whichever setting. So I think this is pretty much the same thing. Darolutamide has a low risk of clinically relevant adverse effects, which may lower the burden of managing comorbidities. So it's new standard for the patients with hormone-sensitive prostate cancer. It's a potent ARI with robust efficacy, of course, and a favorable tolerability. Low risk of clinically relevant DDIs, which may lower the burden of managing comorbidities and requires minimal patient monitoring. So key takeaways, it's the only ARPI prospectively tested and proven in combination with docetaxel and ADT to prolong survival, delay the disease and the pain progression for the patients with de novo and recurrent metastatic HSPC. It's the only ARPI to demonstrate strong efficacy with more than 30% reduction in the risk of death in combination with docetaxel with a favorable safety profile. Discontinuation rates were similar between the two arms. So piece one has several issues, with respect to the risk reduction was 25%. Of course, there are several risks of hypertension, hepatotoxicity, and risk continuation rates were higher. So with that, I'd like to end and back to the organizer. I'll be happy to answer few questions if there are any.
Thank you, Dr. Anshul. Piece one definitely has improved the outcomes in prostate, and as you mentioned, there are certain limitations to it.
Right.
Moving on to further, Dr. Ashish is here with us, and he would be discussing on the metastatic urothelial carcinoma and its management. Please.
Um, all right. So I'll be talking about the current treatment approaches for extending survival in metastatic urothelial cancer or bladder cancer. I think when we talk about bladder cancer, there are two basic populations of patients. One is the cisplatin eligible patients. The other ones are the carbo eligible patients. The tendency to prefer, if they are cisplatin eligible, to still try to use cisplatin in these patients. Really, there's three treatment approaches that, and I think the slide really nicely gives kind of how the treatment of this cancer, which was once considered a cancer, in which we really did not have much to offer the patient before our advanced therapies like immunotherapy, especially, and some of the later therapies have developed. It kind of really summarizes it. One is a wait and watch approach, which is usually what we use in most cancers, or used to use in most cancers, where we first give chemotherapy. You stop after 4, 6, 8 cycles. At some point, the disease will progress, which is the PFS, and then you initiate your second line therapy. And then we like to, the other approach is using switch maintenance that, first line chemotherapy, patient responds to the therapy. You stop and then you switch to immunotherapy maintenance and maintain a response with immunotherapy, low toxicity, etc. and then on progression, then initiate your second line. Or you have continuation maintenance, which has been, kind of the fad now, where you try to combine your second line with your first line, which is typically immunotherapy, combine with chemotherapy, continue the maintenance after you drop the chemotherapy after a period of 4 to 6 months, and then continue IO maintenance, and then when the disease progresses, initiate second line. And so the question really is, for bladder, we've used all three. We currently use, at least two of these. So which is ideal? Historically, first-line chemotherapy, GemCis, GemCarbo, it gave you a PFS of around 5 to 6 months. And then the disease would unfortunately progress. After that PFS, and second line, the pembrolizumab came out. This was probably around 6, 7 years ago. And the total overall survival of these patients was around 16 months. And so certainly an improvement over chemotherapy, which was around 7 months with chemo in the second line setting versus 10 months with pembro. Because the options that we have for chemo in the second line are not great, single agent taxanes, etc. So not a whole lot of great chemo options. And so this was certainly an improvement. It was proven to be in all subgroups, not just in the PD-L1 positive patients. Then came the concept of switch maintenance, where you give chemo, a patient responds with a CR, PR, or stable disease, and then you switch to IO maintenance. And the rationale for this was that chemotherapy is used to decrease the tumor burden, and it's also fairly increases the immunogenicity of the tumor microenvironment. And so that's been a benefit of first initially giving chemotherapy. And the thought process or the logic is that immunotherapy is more effective with a reduced tumor burden and a higher mutational burden. So the cytotoxic effects and the immunogenic effects of chemo provides the opportunity to enhance the clinical efficacy with immune checkpoint inhibitor maintenance therapy. And so that was the basis of the Javelin trial, Bladder 100 trial, in which after chemotherapy, 4 to 6 cycles of chemotherapy, GemCis or GemCarbo, either one, importantly, the patients could get either one of these. So big trial, 700 patients. And then after a response, either stable disease, CR or PR, patients were randomized to avelumab or best supportive care alone. And they saw that this was a very positive trial, changed the standard of care when this trial had come out, in which we saw, if you look at from the beginning of the start of the chemotherapy, the overall survival with avelumab was around 30 months versus 20 months. It's almost 9 to 10 months of an overall survival benefit, hazard ratio around 0.77. So great results. Doubles the PFS around 2 months to 5.5, 6 months, based on best supportive care alone, which is, patients respond and like we used to do in the past, or still if the patient is not affording, then you kind of watch the patients. And as with a lot of these immunotherapies, you certainly see a tail end of the curve here as well, with kind of significant difference to some patients which was unimaginable, kind of prior to this. A couple of things about this trial. One is that you give 4 cycles or give 6 cycles. Certainly there is a numerical difference, but as far as the overall survival, that probably has something to do with the patient population and the tolerability to the chemotherapy to begin with, or the performance status. But it certainly makes a difference in both. So hazard ratios are still very similar. So it did not matter how many cycles of chemotherapy the patient was able to tolerate or able to get for some reason. The other thing, this trial had both cis and carbo candidates, and it made a difference in both. And as we can see numerically, again, the carbo candidates, as we expect, would do a little bit worse. And again, probably has something to do with the selection of the patient to begin with, as far as the chemotherapy. But it did not really matter. Hazard ratios were still, very significant. There's still a big numerical difference, regardless of which chemo backbone the patient initially got. Now, if you look at the response, CRs, PRs, or stable disease, about 10 to 15% of patients had CRs. And so in all three groups of patients, the avelumab made a significant difference, 25 to 40 months, 12 to 20, and 14 to 22 months, even in those patients that had stable disease. So hazard ratio is 0.7 to 0.8, still pretty significant. This was a trial which really represents our population, or the Asian subgroup, or the Asian subcontinent, in which out of the 700 some patients, they had around 150 patients, which were Asians. And in those patients, we can see that we have similar overall survival benefit as to the overall patient population. So 5.5 months as far as PFS, which was similar to the overall study population, and nearly similar as far as overall survival in these patients, 18 to about 28, 29 months from the start of the chemotherapy. Safety profile, kind of similar to what you would expect with immunotherapy, with hypothyroidism, diarrhea, some reactions, fatigue, etc. So, nothing really, kind of different about this immunotherapy versus a lot of our other immunotherapies. But overall, you can see that it was fairly well tolerated. Grade 3 adverse events in the avelumab arm were very minimal. This was then further confirmed in real-world studies in which the PFS was around similar, 5 to 6 months, and the overall survival was also fairly similar. That takes us to our second trial, which is the Avenant study. This was a ambispective. It was a retrospective and prospective non-interventional study in which they analyzed patients that had gotten chemo, then they had gone on to get avelumab every 2 weeks, and then followed these patients. And what they found really, which was surprising in this trial, was that they got the chemo, they had some sort of a good response, they got avelumab maintenance. And then after that, the patients that ended up getting the enfortumab vedotin, ADC, kind of hot kid on the block now, had an amazing overall survival, something that we've never heard of in bladder cancer before, around 3.5 years. So this drug, enfortumab, really worked well after exposure to immunotherapy or avelumab maintenance in this subgroup of patients. So naturally, like in all of the other disease sites as well, we try to combine immunotherapy with chemotherapy. Multiple trials were done. 2 of these were negative. This is now in the frontline setting again, where we're trying to combine gemcis with carbo along with immunotherapy, atezo, pembro, nivo. And the nivo trial, checkpoint 901, was the positive trial, which we'll see. The other trials did not meet their OS or PFS endpoints and/or did not have a significant difference. So talking about the nivo trial, checkpoint 901 upfront. So this was kind of a frontline trial in which combined immuno with chemotherapy versus only chemotherapy in the other arm. And if you see, there was only a 9 days PFS benefit after 7 months of treatment in the overall population that was seen. So 7.6 versus 7.9 months. So not super impressive, obviously, as far as the PFS. So did not really make a big difference overall to the patients. Overall survival, there was a difference, but only 2 to 3 months of a OS increment, 19 to 22 months. So not a whole lot. So if you look at, now, take it as a cross-trial comparison, but if you look at, kind of just the trial itself, the NIVO trial was only in cis-eligible patients, which is fewer patients, especially those that have bladder cancer, kidney issues, performance status issues, etc. The follow-up was also a little bit less than the other trial. We did not have any patients in the NIVO trial, in the checkpoint trial, and if you look at something importantly about the Javelin trial, 74% of these patients, after crossover, the patients that were getting best supportive care progressed, 2 to 3 months. Most of these patients ended up getting immunotherapy, whereas in this NIVO trial, avelumab was only gotten by around 11% of patients. So if you compare just the cis population of the Javelin trial with the checkmate trial, we can see that there was a significant difference as far as PFS and as far as OS, also kind of a bigger difference as far as the overall survival. Then there is that third option of continuation maintenance. So you get, some form of IO, TKI, IO, EDC, frontline, continue maintenance, and then you get second-line therapy. So that brings us to our IO plus EDC given in the frontline, EV plus pembro. A lot of us have obviously heard about this trial. Came out not too long ago, where in the frontline setting, EV plus pembro versus chemo, and there was a big difference as far as the PFS and the OS in these patients. with a hazard ratio. However, the caveat of this trial is a couple of things. One is it did not compare the current standard of care, which is avelumab maintenance. They only compared chemo versus this new kind of combination regimen. And only about 32% of patients received this with a late protocol amendment, the maintenance therapy in the chemo arm. And the other thing is that there are some specific side effects associated with these drugs. So they're certainly not nearly, kind of harmless or nearly harmless drugs with a lot of hyperglycemia, skin issues, rashes that you see, neuropathy that you see in this combination. Seen in nearly 27% of patients versus in the Javelin trial, less than 5 or so percent were grade 3. So coming towards the end of, kind of this presentation, if you kind of look at the summary slide, Checkmate 901, the overall survival was around 22 months. The Javelin trial, we had seen from the start of chemotherapy, overall survival was around 30 months. If you look at the CIS population, this was a little bit higher, 31 months. The EV and Fortumab trial, 31 months was the OS. But if you look at the evidence, the bispective trial, we see that this kind of had a longer overall survival, which we think has something to do with the sequencing of these agents. You first give chemo, maintenance of avelumab, bring the ADC on board, and then you have some survival time, which brings you to 41 months. So the treatment landscape is evolving, certainly a breath of fresh air. There's obviously other drugs as well, which has really encouraged a lot of our patients that, it's not just 1 or 2 lines of therapy, but we certainly have more and more options for you. Platinum-containing chemotherapy is a high response rate, but the responses do not last long, as we know by the PFS of this chemotherapy regimen. Maintenance of avelumab, great advancement, increased the overall survival to nearly 30 months. Overall survival benefit was irrespective of the chemo backbone, duration, response, treatment-free interval, etc. The Nivo plus chemo trial was positive, but as we saw, very minor increment in PFS and OS. Pembro EV data looks good, but toxicities is an issue, and certainly cost is obviously a huge issue for this as well, and availability. And sequencing is important. Right, that's all I had. I'm happy to take any questions if there are any.
Sir, you're mute.
Sorry. Yeah. Thank you, Dr. Ashish. I was just saying that 40 months of overall survival with the correct sequencing of the IO and the ADC. Oh, wow. This was probably unheard of a couple of years back when we were thinking about maybe 1 year, 1 to 2.5 years maximum of survival. Uh, with this, we come to an end of this wonderful oncology update, where we discussed a lot about the hematological malignancies and the newer modalities of therapies, and then coming over to the prostate and the urothelial cancers. Thank you, participants. Thank you, faculty, and thank you, organizing committee.
Thank you, sir. So thank you everyone for joining. And thanks to all the faculties and thanks to our academic partner. Thanks to my colleague Swarangi and Samar and the tech support. Good night, everyone.
Good night.
Thank you, ma'am. Good night.